Hello, everyone, and welcome to another episode of Innova Chats. Today, we have the pleasure to have with us somebody that's been in the industry for quite a few years now on both the provider technology and academia side, Joseph Brence, who goes by Joe Brence, and who is the CEO of Rehab Essentials. We'll go a little bit into what he's doing there and what exciting things he's doing there to really disrupt the space in terms of how we educate future therapists. He's also a professor of business at Carnegie Mellon and NYU. So, without much further ado, Joe, welcome to Innova Chats. Really excited to have a conversation with you today about technology, about the future of education when it comes to rehabilitation. I think that's a very timely subject to talk about today, especially with the scarcity that we're seeing of therapists. So really curious to get your input, your thought as to why there's so little therapists out there to go around. And I'm talking about PT, OT, and speech. Given the rising demand that we have for services, right? But maybe you could tell us a little bit about what you're doing at Rehab Essentials. I think that'll be a great place to start, and we can go from there.
Yeah, absolutely. And Luis, I appreciate you having me on for this discussion today. Yeah, let's start out with Rehab Essentials. So at Rehab Essentials, what we do is that we partner with universities to help them stand up hybrid or flipped classroom models for their therapy education. So whether that university needs a single course that they want to deploy to begin doing this, maybe they have a faculty gap. Oftentimes what we see is that there aren't that many physical therapists that also have specialty areas in pharmacology. So oftentimes we will fill that gap with our digital offerings. But we also partner with universities to essentially deploy a full model, full hybrid-based curriculum that they can plug in either for an expansion program, or let's say that consumers are beginning to prefer this, and maybe they are feeling a little bit of market pressure to adapt. And so what we do is that we take a very consultative approach to not only help them through that change, but also deploy the technology necessary to be able to support that change. And so on an annual basis, through the products that we offer, we interact with thousands of students, both domestically, but also internationally. And we're able to do that through our different offerings.
That's great. Thank you so much for that summary. That's super helpful. And the question that really comes to mind for me is, why do you exist? Right? So, why do we really need to disrupt how therapy education, specifically, for rehab essentials, right? Physical therapy, is being delivered today. Like, why does it need to change?
Yeah, absolutely. And that's a great question, Luis. And maybe I'll start out and just talk about consumers as a whole. So one of the things that we spend a lot of time, discussing both at Carnegie Mellon as well as NYU and my teaching roles is we discuss the evolving preferences of consumers. And so, Luis, or those listening in, I'm sure that when you are purchasing anything, whether it be a box of cereal to essentially a new car, you can continue to go in and do that through a traditional brick and mortar offering. But what we're seeing is that consumers are doing that at scale online. And so number one, from a commerce perspective, we're seeing consumers really begin to shift. I believe that 28% of all goods purchased last year in the United States were done in a virtual means, but there still is a need for a brick and mortar offering. And let's think about consumers with banking. Same thing. I don't know about you, Luis. If somebody writes me a check, which is very rare, I'll scan it on my phone. It goes into a digital app. It goes into my bank account. There really isn't that need to go on site anymore because there's been an innovative solution that I prefer that's just more accessible. And gambling. If you think about gambling, Luis, and I'm sure that a lot of you listening in may have dabbled in gambling. I'm not a huge gambler myself, but if you look at statistics, gambling is now a hybrid-based model. While there still is a need for Las Vegas, but there also is a lot of gambling and wagers that are done online. So if you look at this really across any industry, consumers have adopted hybrid models. And so it doesn't make sense that in academia that consumers are going to continue to prefer simply to have an on-site option. So number one, I think that consumers are beginning to force academia to begin thinking differently. Now, as we begin to like kind of funnel that down a little bit, I think we need to think about how does academia exist in current state? Well, it really exists upon this idea of scarcity. And I want to call out a fellow Carnegie Mellon professor. His name's Dr. Michael Smith. He wrote a book called The Abundant University that he highlighted this.
Yeah.
But there's only a limited number of seats that can exist in brick and mortar educational models. And so what essentially happens is that these limited number of seats are often filled not always by the most qualified student, but by the student that oftentimes has the most means, the most financial means. Maybe it's the regional means. I have a university down the street, therefore I will go to that university. So it's really built upon this concept of scarcity. And that model's got to change. And the reason why that has to change is that I'm also, and one thing about my intro, Luis, also a physical therapist, and I know that you are as well. And as we consider the physical therapy profession, we graduate across all of the accredited universities in the country, about 12,000 new PTs annually. But if we look at the market demand for therapy services, there's a shortfall of about 24,000. And so we aren't keeping up with market demand. And so as you continue to see more demand being placed upon our industry, universities have to adapt. They have to adapt not only because the consumers are beginning to prefer to interact with all industries in different ways, but the current model isn't meeting industry needs. We just aren't graduating enough people. And the last piece around that, Luis, is that when we are graduating people, we're graduating them in a significant amount of debt. The average amount of debt that a PT or new PT is coming out with is about 86,000. But we see a huge variance in terms of the cost in getting that degree. On the low end of the spectrum, we see certain universities, University of Texas Southwestern, for example, has a total tuition cost of about 38,000. But you have on the upper end, you have 6 universities in the country that are above 200,000, with USC currently at 230,000. And so there's a huge differential.
Wow.
As we look at that, we have students coming out with a significant amount of debt. And there was this great paper that was published in 2018 by Dr. Rick Shields. And what it highlighted is that once student debt rises above 150,000, okay, so those students that are going to that more expensive university, there isn't really a net return for that student. The ROI doesn't exist once they are taking out more than 150,000 total in loans. And actually, what's interesting is that once it exceeds 266,000, the financial value of becoming a DPT actually drops below that of the average individual graduating with a bachelor's degree. So essentially, there was no return, there was a net negative return. And so with all of those things happening, with evolving consumers, with this concept of scarcity, we just aren't graduating enough people. And when we do graduate them from traditional models, they are coming out with an enormous amount of debt. That poses a challenge. And what I'll share is that at Rehab Essentials, like we see that. We look at that as being an opportunity to solve some complex problems, being able to meet consumers in different ways, being able to help universities stand up innovative models that reduce their operating costs, that therefore they can reduce their tuition that they're bringing in. So there's ways of being able to manage these, but we have to be innovative to be able to do it.
Yeah, that's fascinating. And I'm so glad to be having this conversation with you because I know there's a lot of people in the industry who are just, living and breathing this problem, right? Like we have customers in long-term care and skilled nursing facilities, assisted living facilities, they just cannot find therapists, right? I mean, PTs, OTs, speech, it is right now the hardest problem, right, the industry is facing is, yeah, we know that demand's there. There's a lot of patients that need our services, but we cannot find therapists, right? And even like with the telehealth mandate, which I find ridiculous that they keep kicking it out of the chain, like down the road. Although it will hopefully become final that it's here. Telehealth is not being used anymore for rural areas, right? Like before, it's like, oh, we're using telehealth because it's the only way for a PT to evaluate or OT to evaluate a patient in a rural area. That's gibberish. It's absolute gibberish. We're not using telehealth to see people in rural areas. We're using telehealth just because there's not enough therapists to go around, right? We're working with, locations in metropolitan areas that are using, telehealth heavily because they cannot find therapists, right? So my question for you is, is this a problem because we don't have enough seats, right, in the universities, right? Or is it to be able to bring out, right, the level of clinicians that we need, with the rising demand? So is it a capacity problem, or is it that we're losing the interest of young students that want to be therapists, but they're like, ROI on this is just not there, right? And I don't want to be in school for 7 years. I might as well just stick it one more year and be an MD, and I'll see an ROI. Or I might as well just focus on another career, right? So is it a capacity problem? Are we losing students because of the price tag right now, on the DPT degree, or is it a combination of both? Or what is your thoughts on that?
Yeah, I think it's a combination of both. First and foremost, the physical therapy profession should be attracting the best and brightest. And historically, if we look at that, I mean, physical therapists are very intelligent individuals that, are specializing in movement medicine. I think universities, typically aren't accepting every applicant coming in the door. I think most, universities, in terms of their physical therapy programs, are accepting, anywhere from 15 to 30% of the applicants that are applying to their program. So I think that we're still seeing applications come in that door. That said, the number of seats that exist in these programs just isn't able to meet market demand. And I think what we're seeing, Luis, and I'm glad that you brought up the post-acute setting, is that when we look at the older population that's dependent upon our service, that's going to
Yeah.
be, heavily reliant upon the post-acute markets. Number one, we have 10,000 people turning 65 years of age every single day in the United States. And by the year 2030, we're going to have roughly 37 million people over the age of 65 that's placing demand on our services that we haven't ever, seen before.
Okay.
And so there's different ways that you can react to that. So if we study other industries, you can deploy one of three things, or a combination of one of these three things. Number one, we can think about people. How can we create more qualified people to be able to care for the demand that's being placed on the industry? So this is where at Rehab Essentials, we partner with universities to help them be able to scale their ability to serve more students. And again, that's taking maybe a very traditional model that had a limitation in number of seats because, staffing ratios, but also just the number of seats in classroom only can hold so many. We're, able to help them imagine with an expansion program to be able to serve more. But
For instance.
people is a current constraint, but it is, one thing that you look at. The second thing you look at is process. So have we deployed the right processes to be able to solve this problem? And so I think that, to your point around telehealth, I think during COVID, what we saw was that the process and the delivery of healthcare had evolved pretty significantly. But it's almost kind of shifted back. And I think what's caused that to happen, and why we've seen, telehealth deployed at scale and then scaled back a little bit, is really based upon the payment models. A lot of fee-for-service providers are still incentivized to bring patients in their door, as opposed to think about more innovative ways of delivering care. So therefore, they default to what they are comfortable with, what's been historically they're within their operating model. But that said, I know that there's been some changes with some updates to the RTM codes, as well as some other codes that have been introduced by the AMA. The third piece that you look at, so you look at people, can we produce more therapists? There's some solutions there. Again, we'll talk a little bit, more about how that gets deployed, process. The last thing you look at is technology. And this is looking at how could we really innovate the way in which patients, receive care. And that's not simply telehealth. What I think about when I think about telehealth is really the same level of care that's being provided in brick and mortar, but you're doing it synchronously online. Very similar to this discussion. You and I, Luis, could have a discussion at a Starbucks. We're having it over Zoom right now. So when I think about technology as solving the problem, it's reimagining how can care be delivered. And one of the things that I was working on when I left MedBridge, and by the way, just for listeners listening in, I spent the past 5 years at MedBridge before joining Rehab Essentials, oversaw strategy there. We were looking at how can digital technology innovate the way that patients are triaged into care and then receive care. And so we were working with health systems that had 3 to 4 week wait periods, and essentially looking at how can we leverage AI to help triage patients into the right care pathways that would be overseen by a clinical provider on the back end. But that said, help progress a patient when they're not in clinic with you. So it's, again, reimagining the way the care gets delivered. But we need to really think about those three things. And what I'll share about, Rehab Essentials is that we rely heavily upon how can we produce more clinicians, but also how can we enable them to reimagine care as well. So within our curriculum, because the universities we work with are deploying us in either a flipped or hybrid-based model, they're incorporating a lot of technology in their practice. We really want to ensure that we are preparing that digitally enabled clinician to begin thinking about how can we innovate the way that we're reaching our consumers.
Well, I love that. I love that concept, right? There's a lot there I could dig in. So let's dig a little bit more into the mechanics of if we want to be able to not have this constraint, right? And use technology to, I think your words before we started recording were like abundance, right? It's like we don't need to be constrained like by the physical seats, right? And as such, if we adopt that mindset, we could, have more of an abundance type of mentality where like we can bring in more therapists into the profession. Tell me a little bit about how you partnering with universities, to do that, right? That's one question that I have for you. And the other question that I also have for you is I'm really interested, in understanding how you're working also with universities and what universities are doing to help therapists become digitally educated, right? Like, how do you educate them on digital health, right? Because I think that's a really interesting topic. So you can take the first one and then I can remind you of the second.
Okay. So Lisa, as we think about, abundance and how do we partner with universities to help them reimagine the way that they operate to create more therapists, I think we need to think about just the concept of innovation first. So maybe I'll start there and then kind of funnel down, how do we apply that concept to our partners? So one of the courses that I teach at Carnegie Mellon is called the Strategy and Management of Technological Innovation. And essentially, in a nutshell, what that means is that I teach, and I know a lot of those listening in are therapists. I actually teach software and machine learning engineers that essentially have developed a really cool maybe application or code, but it doesn't mean anything to the consumer. So essentially, I teach them how do you build a business model around this that ensures it's desirable by consumers, that it feasibly could be deployed at scale, and that it has a viable revenue opportunity that can be built into a business. Okay, so that's a course I teach, and one of the first concepts we talk about is the concept of innovation. And so when we think about innovation at the highest level, it's improving, or it's asking how do we improve or solve a problem in a newer, better way. So what you have to look at and understand is what does current state look like? And it's not taking current state and deploying a new way or ensuring a new way of deployment of that model. It's instead reimagining what could this look like if we were to build it with the technology that exists today. What could a new DBT program look like? Okay, and I think that's challenging for a lot of universities. because essentially they know what's existed at their university for the past 20, 30 years. And they think about technology and they think about taking that and simply just taking that and putting it into a digital box, whether it be deploying on a learning management system or others. And so what we do at Rehab Essentials is we help them through the innovative process. We're very consultative in nature to help them begin to think about two different things. How can we leverage technology to interact with students in new ways? So when universities are looking at taking a brick and mortar model and building a hybrid based version of that, oftentimes the university partners, they might be aware of technology, but they aren't experts there. And that's where we come in. We can help say, hey, here's how you can leverage AI within your model to maybe interact with a student, to help coach them through their journey at the university. So number one, you think about technology, but also we have to help be consultative to universities around their business models, because their business model, very similar to when I was talking about fee for service, and that's why telehealth has kind of shifted back. You have to help them reimagine. All right, historically, your business model has been we are going to accept 40 students. We are going to charge them a total tuition cost of 100,000. They understand what their revenue is going to be.
Right, it's predictable.
It's very predictable. And so when essentially we come in, we say, hey, let's reimagine what this looks like. What if you were able to educate 80 students, but being able to do that in a hybrid way? And maybe you can deploy more cohorts than what you could do in that traditional brick and mortar program. We have to be consultative, with them through that innovative business model, helping them reimagine not only deployment of the education, but also how are we going to make money off of this as a university and how can we sustain? And so we are very consultative from the beginning. So oftentimes what we'll do is we'll partner with universities when they're thinking about either taking that traditional program and building hybrid. So we're very consultative in that process. We're also consultative with universities that don't have a physical therapy program, but they want to build something. And that's where I see a little bit more flexibility from the university's end, because when we're building something brand new from the ground up versus taking something that exists and beginning to adapt it, it's just a little bit easier. We have a little bit more flexibility in deploying more of these innovative things.
It's the whole innovator's dilemma problem, right?
It is the innovator's dilemma. Dr. Clayton Christensen, fantastic
book.
For any of those
rest in peace. Yeah, that's right. One of my favorite books, by the way. Yeah.
I did an executive certificate through Harvard and was able to learn from him years ago, Luis, and a phenomenal economist and consultant, just a brilliant man.
Yeah.
But when I talk about this concept, and let me give a concept outside, or an example outside of Rehab Essentials. So there's a university out there in the market, Southern New Hampshire University. I don't know if those listening in are familiar, but they have a very compelling story. So before 2003, they essentially were operating at a loss. The brick and mortar institution, they were bringing in about 24 or 2,500 students a year into their programs, but they were really facing a dilemma on how do we sustain. So they brought in a new leader at that point in time that really reimagined two things: reimagined the educational delivery model, but also reimagined their operating or business model. And so what they did is they deployed essentially a virtual university in conjunction with their brick and mortar university. And what that's been able to do is take their student enrollment from 2,500, and again, that 2,500 being local to New Hampshire, to they now impact 170,000 students annually. And so,
wow,
it is. And what they've been able to do is go from scarcity to abundance by deploying technology and reimagining the way that we can interact with students. And what they've been able to do as well is by operating at that level of scale, they've been able to scale back their tuition costs significantly. Where now it costs about $3,000 to $10,000 per year to go to Southern New Hampshire University, because they are operating at a significantly different level of scale, and they now have margin. So again, they were able to completely reimagine. And so what we do at Rehab Essentials is that we help universities reimagine the way that they're deploying their education as well as their business models to really be successful in this evolving climate.
Yeah. That's so interesting because, you're consulting, with large institutions, right, that have been doing this for years in a certain way and trying to adopt change, which is not easy with the tools that you have available, right? There's some constraint there, right? Because again, the innovator's dilemma, right? That's their, they've been doing it that way. That's the cash cow, right? If we introduce something new, we can cannibalize, you run into all kinds of issues, right? When you're trying to disrupt yourself, right? Again, the innovators them, right? But and you guys are doing it, right? With technology and with the consulting. But if we were to like, if you were to start a DPT program from scratch, because we have to have a DPT program, right? We have to graduate DPTs, right? And here's a magic wand, Joe, with all the technology that's available today, all the resources that are available today, right? How would how would you do it? What would a startup DPT school look like?
Yeah, absolutely. So Luis, I think it looks a few different ways, and then let me give an example. So, the way that I look at my role, Luis, is that I go out into the market and I'm continuously learning. I'm looking at innovative solutions that not only DPT programs are deploying, but I'm just looking at universities as a whole. So I look at, part of my role is really understanding what's happening in the market and how can we continue to kind of push the envelope, for our profession to evolve in a very similar way. But a couple weeks ago, I was out at Harrisburg University. And Harrisburg University, they are developing a new DPT program from the ground up. They just went through their initial CAPT site visit. The program's being led by Dr. Tanya Miller and Dr. Francois Brzezinski. And what they essentially have set out to do is to create an extremely affordable program geared at a couple different audiences. But those couple different audiences are essentially the learning adult. So that practicing PTA that wants to become a PT, they have a bridge program for them. But they also have an entry-level DPT that essentially is trying to reach those that want a hybrid-based model that they can continue to work in their role, whether they are working in finance somewhere but want to make a career change to become a DPT, or in another profession. So they're reimagining how that education gets delivered. And I saw a few really interesting things when I was there. Number one, saw how are they reimagining anatomy lab? And Luis, I don't know about you, but when I walk into an anatomy lab, when I walk into at my alma mater, which was Duquesne University, you walk into a lab that has a bunch of tables, cadavers are on them. That smell, I don't know if you remember
The
the
formaldehyde, man.
chemical smell,
The formaldehyde.
the
Oh
formaldehyde.
yeah,
Yes,
that brings
it
me
was
back. Yeah.
so that is that traditional model experience, which is great. But what when you look at that model, one of the biggest challenges that I had when I was taking anatomy was when I was studying for my practical exams, when I'd have to go in and there was a cadaver and there was like a little pin sticking out of the finger, and I'd say what muscle that was. What I was looking at in the lab was different than what I was studying. So when I was studying in a textbook. It looked a little bit different than the cadaver, right? It's a different experience.
Totally.
What the University of Harrisburg has done is they've created a VR anatomy lab. So essentially, not only do you have the ability to interact with, and in this instance, it is a replacement of a cadaver. So they have like physical bodies, but they aren't, human bodies. They are replicas of human bodies. But they also have the ability to put on a VR headset that the student can take home and do their anatomy lab through that VR headset. So now you have this portability of the lab from the
Oh
actual
man,
lab to
love
your
it.
home. And
That's
so
so
as
cool.
you're studying,
Yeah.
Luis, you weren't trying to think about like, ooh, when I see this pin sticking out of here, here's what it looks like in the textbook, but here's how I'm going to translate that to the actual lab. Like they're able to take that with them. And so that is reimagining and solving a problem in a new and novel way with technology that exists. And
Mhm.
what I saw at Harrisburg was a ton of that. I saw a ton
Yeah.
of reimagining how can we actually interact with students through our courses, whether it be through didactic instruction, whether it be through laboratory experiences. It's just really neat. So in terms of the way that I would look at this is I would look at very similar to what they did. What technologies exist in the market? how can we leverage them to be able to solve problems that historically have existed in brick and mortar for students? And that's like the deployment of the education model. And then from a business model, I would be looking at how can we operate differently than how DPT programs have in the past? One of the biggest hesitancies in programs shifting from brick and mortar to hybrid is disrupting their operating model. So, how can we
Right.
reimagine what staffing looks like? How can we reimagine what our didactic education looks like, or how we coach our students? One thing that I saw at Harrisburg as well, and I hopefully I'm not sharing too much of their IP, but they've essentially developed this AI coach. And what's interesting, Luis, is
Yeah.
when I was in PT school, school always came fairly easy for me. There's a couple of courses that I struggled in. But when I struggled in them, I just simply would read more. I would. What this does that's different is that AI is guiding on where your shortfallings are. So essentially, it's saying, "Hey, Joe, I noticed on the last exam you missed these three questions. These three questions were maybe phrased in a very similar way. When you see questions phrased like that in the future, here's how you approach them differently." Think about
Very
that.
cool.
When you have
Yeah.
that AI coach in your pocket that's scraping your data to help you understand how to learn better,
Mhm.
that is solving a problem that's historically existed in our brick and mortar institutions. So,
Yeah.
building from the ground up, it's reimagining how we solve problems that exist in our current model. And it's understanding what problems exist for the consumer. It's not us saying
Yeah.
as
Right.
academia, here's what we think we need.
Yeah.
We need to listen to consumers on what they need.
Yeah. That's fascinating, right? Because that kind of like that model, right, is really tackling the problem that we started analyzing here in this conversation from both angles, right? You know, we've had online learning tools now for many years, right? So it is only natural that we need to introduce more of that to solve the capacity problem, right? But with all these other technologies like you're mentioning, for example, in the lab, like as a student, right, I might not need to be going to the lab like 3 days a week or 5 days a week, like we used to do when you and I were in school way back in the day, right? Because you can put on your VR headset and look at the the cadaver and dissect it there, right? And that also would that drive costs down, right? Can this and also the speed, right? At the rate at which you're learning, like you're talking about, like the VR technology, the AI technology that allows you to see your shortcomings, right? Can you
Yep.
speed up the learning, right? In where like it's traditionally 3 years for a DPT program. Can we bring it down to like a year and a half without sacrificing the quality of the clinician that you graduated, obviously, right? But can you create now a program that you get the same type of education, quality education, and speed it up and
Yeah,
drive the cost down?
that's a great question. So what I do want to put out there is that there still are constraints, and those constraints are around accreditation and the standards that essentially CAPTI has outlined, lined out in terms of what comprises a DBT program. So there are
Sure.
certain constraints that simply we can't get around in terms of, the number of courses or credits that an individual has to complete to earn that DBT degree.
Right.
But the way of controlling costs, there's a few things that we can consider here. We can think about number one, how can we, control some of our operating costs? So just the management of cadaver labs, like we were talking about, that's really, really, really expensive. And if we're
Sure.
able to deploy a virtual solution that meets the consumer needs better, and we're able to do that at a fraction of costs, now we've essentially lowered operating costs. The other
Right.
consideration is, student to faculty ratios. So there's a concept, and the concept it's not outlined as a standard by CAPTI, but there's this perception in academia that we need to have so many faculty members for so many students. But I think we can reimagine that as we deploy AI and other solutions to interact with students. Maybe we don't need 12 to 14 faculty members on staff. Maybe we can cut that down to 7, but now we have technology making up that gap. And so as we reimagine the operating costs of deploying these courses to interact with students, while we have constraints from that perspective, from the number of credits that a student might need, we can reimagine how do we operationally do that, and how many students can we reach now that we're not, confined to the number of seats, particularly in a classroom. We can begin to expand it through the use of technology as well. So you potentially get more revenue in the door, decrease operating costs. What you would hope would happen is that the university would then lower tuition costs, similar to what we saw at Southern New Hampshire
Right.
University.
Right, right. Yeah, precisely, right? Because that is, again, from the beginning of the conversation, it's a big problem, right? With the ROI, right? When you said six schools that are over 200,000 K, I mean, it's crazy, right?
It
Um,
is.
Students are gonna be, graduates are gonna be paying off that debt for years to come and not being able to afford a mortgage, right? Because, for the family, because they have this huge debt. So I think that's fascinating that technology can help us do that. But like you said, there's still constraints, right? Because it's, obviously, we have an accreditation program that we must continue to abide by to be able to, safely produce, clinicians. So I totally get that, right? In the educational, field, what are some of the things that you're seeing out there, through some of the customers that you're working with, or I don't know, maybe, with Rehab Essentials too, in terms of like how programs are embracing digital health. Is that becoming a topic? Is that becoming like if you're talking about accreditation, right? You have anatomy's got to be there. You have exercise physiology's got to be there, and manual therapy and whatever, right? Is digital health now part of that?
I would say not across all universities. So it's really
Yeah.
right now very variable in nature in terms of how universities, blend technology and digital practice into their education. I think, a lot of students are beginning to be exposed to different technologies when they go out into their clinical rotations, whether they go to a private practice that's begun incorporating remote therapeutic monitoring into practice, or they're going to, maybe a skilled nursing facility that's using some type of risk stratification tool. They're starting to see that out in practice, but there's a lot more that I believe universities can do to prepare that digitally enabled therapist. And there's reason why that's really important. One of the things that I teach in my courses at both Carnegie Mellon and NYU is the concepts of disruption. And I think as a profession, um, we've kind of had this mindset that we will never be disrupted. Is that there's valuable, there's value to my hands, there's value to what I do, there's value to people coming to clinic with me. But you're starting to see disruptors enter our market. They might not be, going directly after fee-for-service contracts, but you have companies like Hinge Health and Sword Health and Kaya and others that essentially are
Yeah, they're
beginning to
multi-billion-dollar valuations, by the way, right?
Oh, multi-billion
So
dollar valuations. Yes. Yeah. Hinge just went public.
yeah,
So you see these companies that are beginning to offer, and I know a lot of therapists listening in will say, well, they're not offering the same service as us. There's questions on whether they're actually offering physical therapy. They're offering at least an alternative to patients. And there are certain patients that are choosing that. And we can't ignore that. Both Hinge and Sword are doing millions of episodes of care a year. And so they're actually doing this at scale. And for us to be able to protect our profession, and for those listening in that might have a brick and mortar a practice, it's really beginning to think about, all right, a portion of my patients, they're going to commit to 3 days a week. They're willing to come in. Maybe they don't carry a high enough copay. Maybe they have the time to come in, but there's a lot of people that are really busy that have economic challenges that say, I can't afford a $50 to $75 copay, or I carry a $5,000 deductible. I just can't afford to pay towards that. And we'll say, give me my exercises, I'll do them at home. And
yeah,
so we need to think about those consumers. How can we begin engaging with them and not simply dismiss them because they can't, afford to come to see us, whether afford the time to come to see us or afford the financial barriers to come to see us. And so we need to think about, how do we leverage, remote tools to interact with them to continue to progress their care, but not be able to, place a huge burden on them. And so we need to prepare clinicians to be able to think that way, to be innovative. And what we see in students that go through our programs, they're being prepared in a hybrid-based model. They're leveraging technology in their learning, which is helping make them aware. At University of Harrisburg, for example, they're using VR headsets for cadaver labs. They can begin thinking about, well, how could I incorporate that into my clinical care because they've been exposed to the technology, or they've been exposed to AI that's able to coach them through their academic career. How could I deploy something like that in my clinical career? And so I think by exposing students in these innovative models, you then are creating those students that probably are more equipped to not be disrupted by, the hinges, the swords, the other disruptors that are gaining market share.
Yeah. Yeah, I totally agree. I mean, I think it's just a matter of time before like schools start, embracing a more formal type of digital health sort of course or just embracing it in their program, right? Because we're seeing it now, pretty much, everywhere, right? And which leads me to the next question because I know that you're really into, innovation and you're really into technology and have also worked with the public sector, right? What are some of the technologies that you're seeing out there, right? Um, that you're finding to be truly disrupting rehab right now? It could be in any setting, right? And you cannot say AI.
All right, I won't say
Well,
AI.
I just, of course, I'm kidding, but because AI's got to be part of that conversation, right? But in what particular use case, right? So what are some of the things that you're seeing out there that are really piquing your attention?
Yeah, yeah, and so I'll share some examples from both my time at MedBridge, but also what I see and working with industry partners through Rehab Essentials. So the first is I think when we think about technology, a lot of times we become very focused on the technology itself versus the problems that exist. And so when we frame it as the problems that exist across rehab right now, there is currently significant wait times to see the majority of providers. Okay. So if you call a health system, rehab department, and you say, hey, I'm, injured my knee, I come, need to come see you, you'll probably be waitlisted for a few weeks. And so number one, that is a problem that technology could solve. And so one of the things that we were doing at MedBridge was, well, how can we help triage and introduce a clinical pathway before that patient actually, is able to make it into brick and mortar care? So there's an virtual evaluation process to help triage that patient, give them technology during that wait period. Because what we know is that every day that patient waits to receive care, the probability of their total cost of care goes up significantly. And so the quicker that we can intervene, the better. Dr. Julie Fritz out of University of Utah, she's done a ton of research on this. So technology to help triage patients, to determine who can we begin interacting with earlier, who can we give some type of even a pre-plan of care to while they're waiting to get in and see a therapist. The second piece is that schedule management. So it's not only triaging to get the patient moving earlier, but it's how can we better risk stratify those people that are calling into schedule to determine who needs to come in tomorrow versus who can wait for a few weeks. And so there's some pretty cool risk stratification software that's been deployed across different settings. One that immediately comes to mind is being leveraged in home health right now, and it's called Metalogix. And what Metalogix does is it essentially helps determine how often does a patient need to get seen. I don't know about you, Luis. I've had a physical therapy license for close to 20 years now. If somebody asked me, why did you choose 3 days a week versus 2 days a week? I don't have a good answer. I don't know why I do that. I feel like sometimes people just need more help.
4 weeks also the magic.
4 weeks, 3 times a week for 4 weeks. Yeah. So what this does is it takes a very analytical approach to determine who truly needs to be seen a few days a week, who can be seen 1 day a week. It helps leverage the ability to make decisions. And why that's important in home health is that very similar to all other settings, there's a capacity issue right now. And so it helps them determine who needs more care and who doesn't. And it's not to be mean to the patient, just certain patients we all know need more on-site visits than others. And the last piece is when we think about not only triaging, but once we see that patient, how can we retain them? And when I think about patient retention, I think about how can we continue to engage in understanding what's happening when they're not in clinic with us? And how can we create value from that? And so there's different software out in the market, both wearables as well as software that helps us remote monitor patients. So essentially gather data on when that patient's not in clinic with you that you can then act upon as a clinician. And just think about it. I wear an iWatch every day. It tells me number of steps I do, tells me heart rate variability, tells me how many flights of stairs I've climbed, tells me a lot of things, loss of balance. Thank God, like I'm not getting alerts that I'm, at a high fall risk. But that said, there's a lot of great data that's being collected by individuals daily. How can we leverage that as a profession to be able to engage patients in new and valuable ways? And I think as you think about that technology piece, there's a lot of great technologies, but we need to back up and understand what problems are facing our clinic or our skilled nursing facility
Right.
that we then need to, get an innovative solution to solve.
Yeah, totally. Those are great, problems that you just mentioned. I fully agree that, you're looking at the problem always first, right? And then, because the technology that we apply to the problem might be very simple, right? It might be you know, a spreadsheet, I mean, you never know, right? Like, it might be a very simple solution, right? Or, you might need some more sophisticated, LLM model large language model to figure something out, right? But those are very, I think, very good examples. I want to end it, on the clinician side, right? And I'm starting to see a lot of really interesting tools that are out there, right, to help the clinician, better deliver care to patients, right? A lot of these technologies are being used, obviously to run and operate, a clinic, right? To be able to schedule patients and so forth. What is it that is at the clinician's hand now, right? And just to give you an example, right, like we talked about evidence-based practice, right? And clinical pathways, right? I've been playing around with all the models, right? And I particularly like Anthropic, with Claude, in some of the things that you can do more on the medical side, right? But when I put in, a plan of care, for a patient, and I ask the model to recommend me, right, some clinical pathways and to cite the research and all that, I get some very good answers, right? From the model, right? To your point of like why the patient is only being seen, like 2 times a week versus 3 times a week. Well, what does the evidence tell us based on this patient profile, right? And I know that when I graduated, evidence-based practice was like you must have evidence-based practice. I think now we can have it in our pocket, right? What are some of the things that you're seeing like that, right? Like in terms of the clinician that they can leverage to be able to deliver better care or more efficient care.
Oh, absolutely. I think there's, a lot of tools that exist, and some of those tools weren't particularly built specifically for the physical therapist. So we need to think about, outside of our industry. So, for example, let me just give you an example. Again, I've been a licensed practitioner for a long time. I've not treated a patient for, probably since 2012, 2013. So please don't ask me like specific clinical questions. That said, my son recently had a rash. Okay. And ChatGPT just released ChatGPT 5. It's a much more intelligent GPT model. And I simply took a picture of his rash and I typed in the symptoms and I said, hey, what is this likely? Like what should I do in this case? And it went through a very logical clinical reasoning process that essentially led to here is what's likely happening to him. Here's something that you can try off the shelf. And if that doesn't work, follow up with your practitioner. And so I think we're starting to see these GPT models very quickly gain clinical reasoning and clinical intelligence. And as much as we'd like to say, no, that's never going to replace my brain, it's pretty impressive. And I think it's
Yeah.
something that we should consider embracing. I remember years ago when I was in private practice, there'd be occasional times when a patient comes in, with a diagnosis that I wasn't aware of, or like, oh God, what is that muscle again that like fits right here? And so I would look up in my clinical textbooks. Now
Yeah.
you have the ability to essentially query these co-pilots or assistants that literally fit in your pocket. So I think different GPT models should be embraced in practice. I would make anybody aware that the majority aren't HIPAA compliant, so you don't want to feed it specific
That's
patient
right.
information. But
No. Yeah.
You can ask it certain clinical questions, and it can help you clinically reason. I recently heard a podcast that essentially was advising new medical students and new law students, hey, you might want to consider going into those professions because GPTs essentially are gaining equivalent knowledge to what you're gaining and probably are going to be very disruptive to both medicine as well as law over the next few years.
Yeah.
That said, I think that those clinicians that are adopting these things, that are keeping GPTs in their pocket and leveraging them in intelligent ways, are going to
Yeah.
be able to sustain in this evolving environment.
Yeah, I totally agree. To me, there's a parallel to that with a hybrid model of digital practice, right? Like I, this is my personal opinion, right? I don't see why any clinic out there, should not embrace, right, a digital health solution for their practice, right? It just makes a lot of sense, you know. Uh, to me, the days of like, oh, we need to always use our hands. There's a time and place for your hands, right? But some patients don't require it. And do they need to step into the clinic? Not necessarily, right? So why wouldn't you embrace a hybrid model of care, right? We know from the evidence too that it makes sense from a clinical standpoint that we get good outcomes, right? So I think all that resistance, over the next few years are going to continue to drop down, dramatically. You know, um, at some point in time though, like you cannot treat, a post ACL, right? That's fresh, out of surgery, without them having to step into the clinic. The outcome's not going to be quite as effective, right? But can you, seem fully remote, and 2, 3 months later, and just come into the clinic once a week for sure, right? So I think the resistance is going to continue to go down because people like you that are championing and trying to disrupt different models, and so thank you, Joe, for sharing all that knowledge with us. It's been a fascinating conversation, and really wish you all the best with the disruption that you're doing, to develop more clinicians, right, and to find new models to tackle this huge. I honestly, I think it's a massive problem, right? This shortage that we have of clinicians, right? And I want to thank you and your organization for doing something about it. And thank you for your time on this show as well, Joe. And all the best to you.
Luis, I appreciate your time as well, and thanks for having me on.
Yeah, of course. Okay. Thank you, Joe.
Thanks.